contraction heart failure. And sir, my first question is, in this COVID time, you will find that a lot of people are having breathlessness, difficulty, fatigability in a lot of people. So how you are going to, in your OPD, in your clinical practice, how you are just distinguishing that these are the target people? I should think that probably they have heart failure is there, and I should expose those people to other tests, or I should do additional tests in those group of patients. How you are going to see in those groups in your BGOPD?
See, in COVID patients, your ejection
I'm not telling COVID patients. I'm telling because due to COVID, a lot of people will come post-COVID with breathlessness, fatigability. It's quite common in those group of patients also. How you are going to distinguish whether this is due to heart failure, or we cannot expose everybody to additional test, everybody. So how you are going to?
The best thing would be to do is a biochemical marker, number one. Unless the patient has myocarditis in COVID, the NT-proBNP will be high. So there is a confusion. But you see, you don't depend only on NT-proBNP. You have to do an echo in all these patients. If you see that there is diastolic dysfunction, there is a difference in the EAE ratios, then definitely your patient is having heart failure. So you have to be very careful about it. This patient needs a little more detailed workup than what is usually done.
Okay, thank you, sir. And my next question is to NUCD, sir. Sir, actually, you have discussed about SGLT2 inhibitors, GLP-1 receptor agonist. Prior to this SGLT2 and GLP-1, can you focus that probably what are the drugs which are specifically focusing on the CKD patients, or what are the, because whatever we have discussed, diet, exercise, everything has actually some additional role that helps for the good functioning of the kidney, but they're not targeting or they're not directly helps in the improvement of the functioning of the kidney. So prior to this SGLT2 and GLP-1, what are the drugs you think are actually good, or they're really targeting to the kidney?
Only two drugs which are proved, that are proved stood at the time, that is ARB and SN inhibitor. No other drugs proved in long time. So these are the two drugs which helps in the prevention and progression of kidney disease. And all other drugs which are tried had been failed.
Okay. Thank you, sir.
Sir.
Anything to be added by anyone?
No. Just a question for Dr. Mahanti.
Yeah.
Sir, what is the role of finerenone? What kind of drug? What is the mechanism of action in which it acts in CKD, sir?
And actually, it reduces in a CKD. It is directly does not work on CKD. Actually, it reduces proteinuria. Yes, mineralocorticoid inhibitor.
Okay.
And actually, it acts in the early part of the. Suppose if you give it in the your macroalbuminuria level, then it will work. Otherwise, later on, it is no value actually.
It will not be helpful for those groups who are not non-proteinuric also.
Yes,
non-proteinuric group. Yes.
So
my next question is to Prashant, sir. Sir, you have discussed among that there are 5 pillars of management of heart failure, because you have already discussed all those drugs. So how you are going to positioning those drugs that according to the management point of view, what is the best drug, or should be started first and subsequently what are the drugs to be added, or that is depends on the patient status. Suppose diabetic is coming, you are planning for SGLT2 first, subsequently other drugs. A non-diabetic is coming, you are planning to other drugs, like that. What is your thought process about it?
Whatever has been the consensus in 2021 has been that there are 4 drugs which are effective. And among them, first you have to decongest your patient. That is most important. That is, supposing a patient is congested, first use a diuretic to decongest it. Once you decongest the patient, then you see the subset what you are dealing. Is it an ischemic subset, non-ischemic subset? Now, if it is an ischemic subset, the best thing would be to first give a beta blocker. That is the first thing. And along with the beta blocker, you start, if the patient's blood pressure is allowing, you can start an RD or an SGLT2 inhibitor simultaneously. So the most important thing is what they have stressed upon is that do go for a rapid sequencing of drug. Don't go stepwise that I wait for 15 days, give another drug. I wait 15 days, add a third drug. They're telling that within 4 weeks, 4 drugs have to be given. But in our practice, we have seen that this is not practical because most of our patients don't tolerate so high drugs. So we usually start with the beta blocker, then with an Arni. These are the two drugs which have been proved very well to prevent heart failure. And of course, if the patient is a diabetic, put him on a SGLT2 inhibitor. And then lastly, around the last week, you put on an MRA. But there is a lot of caution over here. If the blood pressure falls to less than 100, be careful about using your Arni. Or even SGLT2 inhibitor can be given safely, but there is some amount of decongestion takes also while using an SGLT2 inhibitor. Lastly, about combining these drugs, one has to take a precaution that you have to do the RFT every weekly, because this patient may have suddenly a shoot up of urea creatinine, and then you have to go back on your drugs. The best thing is that if the patient is a diabetic who is on dialysis, in this patient, you can freely use your that is Arni. It is recommended that do not do any dose modification because the patient is on a twice weekly, thrice weekly. So be aggressive on these patients. So these are certain based on the individual patient that you have to use your drugs. But you do a rapid sequencing. Don't go very slowly on sequencing these drugs.
Thank you. And yes, sir.
I have two questions. I'll ask Bharat. Bharat is one of the panelists. Dr. Bharat, I just wanted to know, you just heard Professor Prashant spoke about SGLT2 in diabetics, but the indications have been that we can use also in non-diabetic. What has been your practice, Bharat, for using these drugs in the non-diabetic SGLT2 inhibitors? And then I'll come back to Prashant. Bharat, you are muted. Bharat, you are muted.
Okay, thank you, sir. So whatever trials we have with us, whether DAPA, HF trial or Emperor Resort and Emperor Reduced, all the trials that have shown definitely the outcome is equal both in diabetes and non-diabetes. So I think again the treatment part, heart failure treatment in diabetes and non-diabetes is almost same. There is no difference in treating diabetes and non-diabetes. But we are now dealing here with diabetes with heart failure. So in non-diabetes also the same thing. Whatever Prashant had told us, starting the drugs. But now there are many controversies. The guidelines, they are not telling about this. They are all telling about the sequential treatment. But there are some expert opinions. What Prashant had told, they tell no, because all the drugs, they are having complementary action to each other. So we should go with a little of drug, maybe reduced dose of all the drugs and start very early, and we should complete within 4 to 6 weeks so that we'll get the maximum benefit. That is what the expert opinion there. So we can do the same thing in whether it's a diabetic or non-diabetic. The treatment is almost same.
And again, sir, in both DAPA heart failure and Emperor PISA reduced, all has clearly shown that non-diabetic has got better benefit than the diabetic.
Yeah,
better benefit in with use of SGLT2. So though it is numerically better, but it's not statistically significant, but it is again numerically better in non-diabetics in comparison to diabetic.
Let us ask Prashant, is he using SGLT2 inhibitors, Professor Prashant, for the non-diabetic also?
Thank you, sir. Yes, I have started, and many cardiologists have started using SGLT2 inhibitors in non-diabetics with heart failure. In fact, this is one of the best drugs we have in our armamentarium. Now, here we have 3 drugs, C, D, and E, CANA, DAPA, and EMPA. Canagliflozin is not to be given to non-diabetic because canagliflozin is, to some extent, has both SGLT1 and SGLT2 properties. And sotagliflozin has SGLT1 and SGLT2 properties. Any drug which has both SGLT1 and SGLT2 inhibition is not to be given to a non-diabetic. All trials have been done on diabetics. But only 2 drugs, the EMPA E and D and E have been done on this thing that is non-diabetics. So, sir, we are using these drugs and we are finding good results. Because something that used to haunt us was that in spite of the drugs that was available, digitalis, diuretics, beta blockers, the patient after some years, we used to send them to have a costly device, a 9 lakhs device of a CRTD or a AICD something. You will be surprised that after 3 to 4 months of therapy on these 4 drugs, this patient ejection fraction improves from 25% to 50%. There are a lot of cases like that. So I think drugs has got revolutionized the treatment of heart failure so far, whether it's a diabetic or a non-diabetic.
Good. I think they
actually I want to.
do we have one short question to Nishin. Do you have time? I just wanted to ask you two things, Nishin. One is about the non-proteinuric diabetic kidney disease. I think you hinted at it. And number two, the diabetic tubular disease.
Tubular disease, I could not understand.
They're talking today about the non-proteinuric diabetic kidney disease. I do not know much about it, but I think we have discussed in many forums. There can be diabetic kidney disease without proteinuria. When the EGFR comes down to much lower level, whatever it is. So we have sometimes the non-proteinuric. Just wanted to know your ideas about that.
Non-proteinuric, actually, maybe the other factors, maybe due to dietary factors or maybe coexisting hypertension or those things.
Obesity.
Actually, to add to that, non-diabetic, this ST2 inhibitor in non-diabetic disease, in nephrology, actually, we have a lot of indications nowadays we are using, and particularly IgA nephropathy and also primary nephropathy, whether if it is not, even it is especially the diabetes. So now, after these studies, actually, we have started using in non-diabetic kidney disease, like IgA nephropathy. And another point, actually, I want to add to Dr. Prashant, actually, this about the decongestion. Actually, what I have seen, because of rapid decongestion of the patient comes to you, heart failure, edematous, give a vigorous diuresis, then actually what happens, a patient that is reduced blood volume, and your once there is a reduce in the blood, reduced blood volume, patient develop AKI. There is increase in your because there is a decrease in the preload. So actually one of the strategy to preserve kidney function. So you should decongest the patient very slowly. If you will be very vigorous in reducing your decongesting your heart failure patient, and he'll definitely will go for a acute renal failure if you reduce your blood volume. So that is why very much cautious when you decongest your patient. Along with this is your drugs, RNA or whatever maybe. Also the RNA also contains your valsartan that can cause hyperkalemia. That thing, even if you are giving it to your dialysis patient, this thing, then you have to look for the hyperkalemia. So that is a big problem, particularly in Indian patient. Hyperkalemia is a very big problem.
Thank you.
Nishit sir, last question is, you have actually touched each and every part of the treatment, but you have not discussed about linagliptin. What is your thought about linagliptin? Because there is a definite study which has clearly shown, it has shown clear-cut improvement in the GFR. Also, it has reduced in the albuminuria. So what is your message about linagliptin?
Actually, I don't know exactly linagliptin. I mean, I don't.
There is actually with linagliptin, there are both the studies has clearly shown that linagliptin can reduce microalbuminuria up to as high as up to 20%. But it is less than SGLT2 inhibitors, but can reduce microalbuminuria. Even if they can reduce the serum creatine doubling time, also can reduce. But it is not as like as SGLT2 what we have. But so looking at this, Lina has among the DP4 inhibitors, Lina has specific effect on particularly specifically on the kidney point of view.
Actually, our national conference, there was a talk by George Bakris, and he was discussing about this phenrinone and these things, and there are big medicines and everything were discussed. So the last point he was telling that it is the basic thing is that you have to control the hyperglycemia, and whether it is a metformin or it is a simple any other sulfonylurea, that is much more important than giving this novel medicines. If the patient is not able to afford these newer drugs, I think the basic thing is that you have to control the hyperglycemia with the least costly medicine, along with the nutritional and your exercise control. I think still those things are most important, more important than any newer drugs.
I think
Thank you.
It was fantastic. I congratulate both and also Dr. Prashant for a very elaborate session on two aspects, cardio and renal, and also cardio-renal. And it has been absolutely fabulous session. Thanks, Prashant, and thanks, Nishint. And I must thank Abhay Absolutely great, great questions, great discussion, great moderation, and also Manoranjan. Manoranjan is always active. Thank you very, very much. It's a great, great session. We're on time. Bharat, thank you very much. Thank you very much. Why this beard has been grown, I don't know. Bharat, absolutely great contribution about everything. Thank you, Bharat. And thank you all. And we'll pass on to the next session of complication 2. I'll request Jayant to call the chairpersons and start the session. Jayant.